Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Janet Jokela. She is the treasurer of the American College of Physicians and an infectious disease physician. Today's Kevin MD article is Navigating the World of Artificial Intelligence in Healthcare. Janet, welcome back to the show.
Thank you so much, Kevin. Delighted to be here.
All right, so tell us what your latest article is about.
Yeah, ACP published a policy paper on artificial intelligence in healthcare this past year. I thought it'd be a good opportunity to kind of highlight that, review that, and chat about this topic with you and your audience.
Yeah, so I think that the evolution of that intersection between AI and healthcare, it's almost changing daily in terms of the applications that AI has and the implications for the way we practice medicine going forward. So tell me some of the highlights for the from the ACP paper.
Yeah, so in this paper, there are 10 positions, and so it's all laid out very clearly there. But there are things like one of them is AI may be thought of more as augmented intelligence as opposed to artificial intelligence, that it's a tool to be used by physicians, that it is not going to replace physicians. It must not replace physicians. So that's one position. Another one is all these principles of AI and AI development and use must be aligned with medical ethics, and that will help enhance the patient-physician relationship and everything else that we hold so dear when we care for patients. So there are things like that that it touches on.
So through your observations, through your interactions in the ACP, and of course you work in academic medical center, how are you seeing AI intersect with what you're doing in medicine on a daily basis?
Yeah, well, certainly in medical education, it's a very hot topic. I mean, how do we teach this to our medical students? What do we teach to our medical students? And how do we prepare them to enter this rapidly changing world? So that's one thing that is certainly high on people's minds. Like, what do we do and how do we do this? So whether that's with medical students or residents, that's kind of a hot topic. In practice, there are certainly a number of practices across the country who are now using digital scribes, which is a really interesting thing. So a physician may have a interaction with a patient, have a visit with a patient, and then at the end of the meeting, the digital scribe will spit out a draft note, and that's pretty cool, pretty cool. And then, of course, there's other avenues that artificial intelligence is being used in clinical medicine, especially in radiology, like say mammography, also pathology, ophthalmology, derm, all of that. So there's that whole diagnostic type activity that AI is doing there, but then also tasks like scheduling clinicians, scheduling patients. So there's a wide array of places where AI is intersecting with us in medicine.
So let's talk about the first thing, medical education. Of course, you are a medical educator yourself. How are medical students and residents and interns, how are they utilizing AI today? And as someone who oversees that, do you see any red flags or potential dangers in the way that your students that you're seeing are using artificial intelligence?
Yeah, good question. Excellent question. One of the main things that we see, and this is a hot topic in the world of publishing as well, but for instance, and maybe not so much medical school, but more undergraduate education, let's say students have an assignment to write XYZ. Do they do it themselves or do they go to ChatGPT to write something or create something to turn in? And that's a really interesting ethical issue, like who's doing the creating and where is this coming from? And then you dive into this a little bit deeper, and then you also realize that the databases that ChatGPT or whatever your system is that you're using is, what's that based on? What's the input into those databases that create the output? And that we don't know, and we don't have control over that right now. And that is a concern because there may be falsehoods or inaccuracies that are put forth as the output, and that can be quite problematic. So it's a challenge these days for how to navigate this and also how to guide students in this kind of the wild west of AI and this digital landscape.
And in medical school and in residency and fellowships, are you or your colleagues giving specific examples of what not to do, giving specific rules, and teaching them the boundaries of how they can ethically use AI when they're learning to become physicians?
Yeah, there's more and more of that. And I think that's growing. I think for many faculty who may not be digital natives, this is just a completely new landscape. And how do you do this? To teach on this topic to students who are digital natives, how do you do that? What does that mean? So absolutely, though, in medical school, in residencies and fellowships, there are efforts afoot across the country and in various institutions across the country to specifically take a look at that, to address issues, address concerns, in many ways, perhaps focus also on the ethics of AI. How do we use this ethically in healthcare and in medicine? And so there's a lot of work being done on that. There's a lot of interest in that, and it's only as quickly as AI is changing, the educational efforts are also changing and evolving almost on a daily basis.
How about the scenario of working through a case and asking AI, for instance, to interpret lab values, coming up with a differential diagnosis? So let's say medical students and residents perhaps using AI for that aspect. So what is the ACP and what is your position in terms of using AI to say hypothetically come up with a differential diagnosis and perhaps analyze a case?
Yeah, yeah, yeah. Now, the paper that ACP just published does not specifically address that. That said, the paper looks at more the fundamental development of AI tools and that as opposed to today being in the clinic or the hospital and trying to sort out what's going on with a particular patient. So that said, it gets back to the database. What are the
Mm.
databases that are being used to generate a differential or a diagnosis, and how confident are we in those databases that they're accurate and that the information there is equitable, say, and all of those things which are important to us in medicine. So again, we're kind of at the forefront of this, and I think there are many people who right now in medicine, in particular, because the stakes are so high for our patients, that we're kind of approaching this cautiously, which I think is warranted and is understandable.
So you mentioned earlier that instead of artificial intelligence, you prefer to call it augmented intelligence,
Yeah.
right? And you mentioned some of the tools that AI can be used, like these digital scribes. And full disclosure, the presenting sponsor of my podcast is a digital scribe company. So full disclosure there. So other than these digital scribes, which I've talked about before on the show, what are other ways that AI can augment a physician's practice?
Wow. Well, certainly with radiology, that's been going on for quite some time, and I think mammography is probably one of the best examples of that. But there's been studies done looking at, who's better, if you will, the
Mhm.
radiologist or AI and all of that. My recollection, my understanding is that what's best is them working together. So the physician, the radiologist with AI to review mammograms or whatever the images are, and those outcomes are better, say, than either alone, which is reassuring in many ways. But that's an example of the augmented intelligence. So the artificial intelligence can augment the decision making of the physician, but not replace it.
I'm happy that the ACP has come out ahead in terms of coming up with a specific policy as it relates to AI. How did the ACP come up with that?
Yeah, good question. The way the ACP comes up with any policies or any positions in this way is that it bubbles up through the Board of Governors. So through from chapters to the governors in the chapter, it's debated and discussed in the Board of Governors, and then it comes to the committees. Well, it goes to the Board of Regents for approval, then it goes to committees for review and implementation and everything else. Sometimes there may be specific issues that also come up within leadership, that whether it's AI or other very timely topics, that the Board of Regents recognizes that this is really important to pursue and address, and then it gets passed on to the committees for implementation and to explore this. So this is not something that is done over the period of, say, 2 weeks. The decision is made that, oh, we need a policy on this, and 2 weeks later we have something. This is a very thoughtful, deliberative process, And so as the policy is researched and then drafted, it comes back to the Board of Regents for review, Board of Governors and other leadership, but to review and provide input and give suggestions, say this, not that, or you missed the boat on this topic, think of it this way, not that way. So again, it's a very stepwise deliberative process, which I, for one, am quite proud of. And then finally, it's approved by the Board of Regents and then submitted for publication. And just because it's a ACP publication does not guarantee publication in the Annals of Internal Medicine. I mean,
Mhm.
the rigorous annals process is applied to these papers as it is to anything else. So I think that's an important piece too.
Are there any other areas of this policy paper that we haven't touched upon? So, what are some of the other main points that you want to bring up?
Yeah, one is transparency, emphasizing the importance for transparency. I mean, can you imagine, worst case scenario, say, by being in the exam room with the patient saying, oh, you have XYZ, and the patient may ask, well, why do you say that? And the response would be, oh, because, in this case, being transparent, the model that I'm using says so. And that's a painful place to be in many ways, not necessarily understanding how the model worked or why the model worked the way it did. But if that's not disclosed to the patient that, oh, this is an AI generated, recommendation for a treatment or an AI generated diagnosis, that's problematic. So the transparency is really important. Another one with related to all of this is also equity. Again, getting back to those databases that are used to build these models, if the information coming into the models does not include patients of all backgrounds or all ethnicities or whatever it may be, that could potentially lead to biases in the output of recommendations for treatment, diagnosis, or anything else. So those are some of the other positions that are mentioned in the paper.
So, how about a message to practicing internal medicine physicians like myself? So, what are some guardrails that we should consider when, like you said, not all physicians may be familiar with the nuances of artificial intelligence? So, someone who is just starting out and wants to incorporate some of these tools, whether there's a digital scribe or asking ChatGPT a medical question, or even thinking about adding personal patient information into ChatGPT. These are all things that cross internal
Oh,
medicine physicians' minds. Well, what are some red flags? What are some guardrails that they should consider before doing that?
yeah, data privacy and patient privacy is paramount. I mean, there are some health systems that have established their own large databases, but have put in place guardrails around that in terms of patient privacy and data privacy. So that's really critical. As individual physicians, unless we're working in a system that has those guardrails in place, we don't want to. In fact, it would be a violation of our oath in many ways on our part if we were to enter information that is protected or is identifiable in some way. We can't do that. That would be an important thing not to do. One place that's interesting that I think is using AI is in an interesting way that I recently heard about is Dynametics. It's something that's available through the ACP, but they've created their own
Mhm.
internal AI system within Dynametics. So when a question is put in, it searches internally on all the references and everything that they have there within Dynametics. And then it, gives you an answer. But I think that's a clever way to put the guardrails around what information is being searched on, as opposed to the whole internet of everything. But it contains the search in a little bit more rigorous way that we know is evidence-based, and that's reassuring.
And for those who aren't familiar with what Dynomedics is, just give us a 20-second blurb as to what that is.
Yeah, it's a decision support tool that it's all online, all electronic, and it's available through the ACP if you're an ACP member, but you can put a search item in there. It might be, say, AFib or treatment for AFib, and it will bring you to the AFib page and treatment, and it will give you references, like short statements, but also references for, the statements that they have there on their website. So it's reference, it's reassuring it. To me, it inspires confidence in what you're saying and in terms of what you're recommending and finding for your patients.
So, in other words, it certainly limits the database to something that is more evidence-based
Yeah,
versus something like a ChatGPT, which uses the entire internet. So it's a more reliable base source where the AI draws upon.
that's right. That's right. Thank you. Yeah, well said.
So going forward, like I said earlier, the evolution of artificial intelligence is very, very fast, sometimes faster than a lot of organizations can keep up with. Just from your standpoint or the ACP standpoint, where do you see AI going forward? What are some predictions that that you may be considering as it relates to that intersection between AI and healthcare?
Yeah, yeah. And another good question. Eric Topol's book, Deep Medicine from 2019, he touches on this. And it's very interesting. His thinking about this suggests that AI eventually may help save physicians time. And he's very, forthright saying, look at, primary care is hard. It's been challenged and in some ways broken in so many ways. It's hard to connect with patients and everything else. Internal medicine physicians and all physicians who are seeing patients to protect that time. So in the sense that if AI does, and if these AI tools do save us time, then we protect that. So it goes back to our patients where we all want to be and where we know it's important.
Do you recall any specific ways that he predicted in 2019 that it would save us time? Certainly, we have a lot of these AI scribes, right, which kind of record things in the background and gives an AI generated note based on the conversation.
Yeah.
Anything specific that Dr. Topol may have recommended that may prove prescient?
Yeah, I think the digital scribes is a big part of it. We know people spend a lot of time on notes, and granted, there are templates in the EHRs that people use, which help as well. But digital scribes, but also billing,
Hmm.
incorporating billing procedures into the digital scribe type system is another way that perhaps that could work. It's also prior authorizations and that sort of thing. There may be avenues for AI to help with that. Now, who knows? I mean, we'll see. AI with prior authorization has gotten some bad press recently, and which sounds like it's well warranted. So we'll have to see how that all involves. But there may be other insurance related aspects of what we do that AI may be able to help with and ultimately save us some time.
So, Janet, you've seen the evolution of various medical technologies throughout the years, I'm sure. Taking a step back, do you ever wish that medicine can go back to a simpler time where it was just the doctor and the patient in the exam room and without worrying or having to come up with policy papers about this new technology? Just from your own personal reflections, do you ever wish that medicine can go back to a simpler time?
Yes and no. I mean, there's been some tremendous advances in medicine. And I hate to go back because we've made some tremendous advances in medicine, which have helped our patients and helped all of us in many, many ways. That said, the whole healthcare infrastructure is a challenge, as we all know. And if there be a way to go back in time to perhaps redirect some of that in some way, shape, or form, that would, that could be exciting. The challenges of finding the time and the attention that our patients need is really critical. And the communication with our patients is really critical. And to go back in time to be able to preserve that in some way, shape, or form would be a lovely thing to be able to do.
We're talking to Janet Jokela. She's the treasurer of the American College of Physicians, and we're talking about navigating the world of artificial intelligence in healthcare. Janet, as always, let's end with some take home messages that you want to leave with the Kevin MD audience.
Sure, sure. There's a couple things. One, AI is here. It's going to evolve in ways that we can't quite predict, but it will never replace physicians and it will not supplant physicians. And then, second, it's critical as AI is developed and used and tested and everything else. It's critical that it's aligned with medical ethics. So it's really important for physicians who may not be AI experts, but to be involved in the development of these AI systems. And then lastly, I think there's a lot of optimism about how AI can help all of us, but I think most importantly, how it will ultimately help our patients. And that's an exciting place to be.
Janet, as always, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
Thank you so much, Kevin. Delighted to be here.